All right, good morning, everybody. Welcome to our third quarter CCT Collaborative, brought to you by the Center for Transport and Resuscitative Medicine. So we're excited this is one of our first events that's going to be sort of sponsored by that group. This is something we stood up here over at Hopkins, so we're really excited about that. Asa can tell everybody all about that at the end, and all the great work we're doing with that. So our third quarter collective here is brought to us by the cases are brought to us by our folks over at MEC. So thank you guys for bringing those two cases, and thank you, Dr. Launer, for connecting us with the folks for those two cases. So first thing I want to do is, as always, we'll introduce the panel of physicians and providers that we've got with us to kind of run these cases. So we'll start with Dr. Margolis.
Yep. Hey, everybody. Asa Margolis, medical director here at Lifeline, program director of the EMS Fellowship at Hopkins. Thank you, everybody, for joining and looking forward to a good discussion.
Ruben Troncoso, assistant medical director over at Lifeline. Morning, everyone.
Zach.
I'm Zach Tillett. I'm an EMS fellow here at Hopkins.
I think that's all of our Hopkins folks. As I'm sure Ben's going to point out, we bring an entire team to all of these things. So it looks like you've got a couple folks over there. Ben.
What's up, everybody? I'm a big fan of the Center for Transport and Resuscitative Medicine. Ben Launer, medical director, Maryland Express Care, Aaron Brown.
Jeff.
I'm Jeff Nussbaum, Assistant Medical Director of Express Care. I just want to point out to Zach, welcome to the CCT. Coach Call ended as Ben's background at the last CCT. It took him a whole year, but he made it there. So you too can aspire to end up as the background of Dr. Launer if you contribute as much as Coach did.
Yeah.
It looks like we got our newest addition. We're adding MedStar to the team this time. We're happy to have them joining us this time. So it looks like we got Dr. Sasser from MedStar.
Yeah, hey everyone. Thank you very much for the inclusion in this. We're looking forward to getting more involved in Hopkins and Maryland's collaborative. So I'm here. I'm the medical director for MedStar Transport, and we also have Jonathan Siegel, our flight manager.
Perfect. And then our invited guest that we can't figure out where she actually belongs. I believe Dr. Torrey's with us this morning. She likes to bridge the gap between Hopkins and shock trauma and University of Maryland. So, morning, Arissa.
Morning. Thanks for having me. I'm at Shock
Absolutely.
today.
We love having you. Where are you at today?
I'm at Shock.
All right. So you get to be on Ben's team today.
Sounds good.
All right, so we'll get started. Our first case is going to be Ian, one of the nurses from Express Care Ground, is going to present our first case. So I'll let you go ahead and get started, Ian.
Hi, my name's Ian Damlor. I'm one of the transport nurses at Maryland Express Care. Can everyone hear me? Is there any problem with background noise?
No, you're good.
Okay, so basically this call happened a few months ago. I walked back into the office and we got kind of really conflicting dispatch information, as is the case sometimes. The first I heard from a fellow staff member was, "Oh my God, thank God you're back. There's a male at outside hospital with a laceration that was bleeding and is now controlled." And I was like, okay. But then my partner read some of the dispatch information, or maybe the consult information, and saw the words cardiac arrest. So we definitely headed out the door and beat feet to the outside hospital. And then en route, we got more information. And then when we got there, we basically found, or do you want me to discuss what I found or what I saw?
We'll get to that in a second. So the gist of it is we got a dispatch for a 30-ish-year-old male, hemorrhagic shock, potential arrest, like you said, kind of blurry information from a dispatch standpoint, vented, a couple drips, got some blood infusing. That's sort of what you got going out the door.
Correct.
And then this is your sort of initial presentation, correct?
Yes, correct.
Hey, Sam, can I be a classic doctor and interrupt the person 15 seconds into the presentation here?
Of course, of course.
Good. That's what I learned in medical school. You don't let people speak, you interrupt. So this is actually already raises such an interesting point for me. Full bias in the air to everyone. I did fellowship at Pitt. I trained with stat, so I'm very stat centric. Despite working for Express Care now, which doesn't love ASV quite as much, though I actively am on ASV at the moment. At stat, when we got dispatched, we got no information. We got where we are, where you are, you knew that, where you're going, and special equipment. And that was very much intentional, that you left the door with the same equipment every time, no biases. And then you got information in the air when you were en route. At Express Care, they are involved in the consult. They listen, they're able to ask questions from the sending and the receiving. And I'm curious what the other practices are at the other institutions. And then we'll get back to Ian, who I've rudely interrupted.
No, thank you. That's a very good question, Dr. Nussbaum, and it definitely highlights the significant differences between programs and facilities.
I could sort of speak on the Hopkins side of things. So we're split, right? Like when we launched our aircraft, Jeff, as you correctly pointed out, right? We just get the minimal information and we get updated en route. Obviously, we use the stat platform and format, right, for our dispatch. And I think that has worked well for a number of reasons, right? It decreases time to the scene. You're not unnecessarily anchoring on things, and you have the standard equipment ready no matter, what you face or what the clinical situation is. On the ground side, we're not always as good at that, right? We involve ourselves in the receiving of the call sometimes. If somebody happens to be up in our call center, we look at the triage sheet. If there is information that's not on the triage sheet that we want, sometimes we will feel the need to call back and get that information. And inevitably that just, again, I think delays time out of the door, and often biases the team somewhat inappropriately, because we know that things clearly change from the time we get the dispatch information until the time we arrive on scene. And ultimately, what it ends up doing is these patients need to get out of those facilities for a reason. Typically, they've exceeded the capacity of the outside facility and they need our services. So the sooner we're able to get the patient back and start taking care of them here, the better off for the patient.
Matt, I'd be curious what you guys are doing, and if there's a difference between air and ground for you guys.
So there's not really much of a difference from air and ground as far as I can tell. So, generally we try to get as much information as possible, which is usually suboptimal. I'm sure that you guys, anyone who's ever heard me talk about EMS as well as the emergency department, knows that I say we try to figure out the right information or the right answer without enough information and assuming everybody's lying to us. And I'm pretty sure that everyone on this call kind of feels the same way quite often. But we get a small amount of information from the sending, as much as we generally need to make sure that we have the right equipment, the right level of care, which is generally going to be SCT for these kind of cases. And I'll let Jonathan chime in from the operations side of it, because he will have more dispatch information than I usually have.
So for us, I guess I can turn my camera on, huh? For us, our crews don't have any part in the consult or the transfer arrangement process, and they will get information on dispatch that's pertinent, but they don't have any contact with the sending until they arrive at the bedside.
Yeah, I mean, I think it's a double-edged sword, like we all talked about. Like, if you're going to give me information, I'm going to ask more questions and I'm going to ask a bunch of information. But I don't know. Jeff, I honestly think I like the being blinded to things a little bit more. Let me just get out the door and I'll figure it out when I get there. But it's a change for a lot of particularly our nurses, where they were used to being in the unit where they can interrogate Epic and get all kinds of information. So I think it's a bit of a double-edged sword. So I'm going to kick back to Ian and let him kind of keep running through this case. But that was a really good. That was a really good question. Go ahead, Ian.
So would you like me to just share my first impression of the patient, my patient impression when we got there, or I'm assuming?
What was your first impression? What was your first impression when you walked in, and paint the picture as to what you saw when you got there? You had kind of conflicting information and kind of a blurry story when you were headed out the door. So tell me what you saw when you got there.
Well, I basically saw a male in his 30s, GCS of 3T, intubated, with a huge laceration, a deep laceration to his right upper extremity, or the right upper part of his arm, that was wound packed and pressure dressed basically, and he was on levofed drip, and I believe, if I recall correctly, propofol, but nothing else. And his pressure he was hypotensive.
Okay. So, and in reading your chart, I gleaned that he had about a 15-minute downtime, PEA arrest on scene. Okay.
Yeah, PEA arrest on scene, 15-minute downtime. They got ROSC. They transported to the closest facility, which was the outside facility where we were in, which was about 20 minutes from us. And he had gotten 4 units of packed red cells, and some fluids, but nothing else.
So 4 packed, because at one point I saw.
Sorry, 4 units of whole blood. I apologize.
4 units of whole blood at the outlying facility. Okay.
Yeah. Yep.
Okay.
And this was before we had whole blood. So my partner and I debated as to briefly debated going out the door whether or not we should get blood at the blood bank, but then we decided, no, let's just go.
Okay. So ED 911 transports him to the outlying ED. They give him 4 units of whole blood. Good for them. Amazing that somebody got whole blood in their ED, readily available. They come on the ventilator and do some wound packing. Did he have a tourniquet on?
He did, but I was told that prior to our arrival, the tourniquet re-bled. So instead of tightening the tourniquet or putting a second tourniquet on, they decided to pack the wound and put a pressure dressing on and control the bleeding that way.
Okay. Was that effective?
Yes, it was. Yeah, there was no bleeding through the wound packing or the pressure dressing.
Okay. All right. So for the physician staff, this is what we get. This is what I walk into. What are my priorities of work here? What am I after? What are you after me working on? Right? Hemorrhage control, like blood pressure is garbage, so probably needs more blood. Correct?
Yep. Yeah. I think it goes back to the, main principles of resuscitation. So stop what's bleeding. Apparently they've gained hemostasis. Agree that I'm not entirely sure why, but clearly we weren't there, and I have no idea what this wound looked like, why that tourniquet was removed. But maybe they thought that was the best course of action. I'd be curious to know, was it packed with hemostatic gauze, or was it just packed with whatever they could find?
I'm pretty sure it was with whatever they could find. I mean, I'm not entirely sure whether it was hemostatic gauze. All I saw was a pressure dressing with elastoplast, basically. A large pressure dressing with elastoplast.
Then we get back into the balanced resuscitation, and I think it was great, that we had whole blood. And we not had whole blood, obviously we'd have to think more about our balanced resuscitation and RBCs, FFP, and platelets. At this point, I think the other sort of part of the balanced resuscitation is calcium, right? And calcium administration. I think we're a little bit all over the map right now with, in terms of when we give calcium. There's evidence that suggests that patients in hemorrhagic shock are already hypocalcemic without even ever getting blood. Now you add blood, and the citrate component of the blood, which is even more pronounced with PRVCs than it is with whole blood. But in any case, certainly after a unit of whole blood or 2 units of whole blood, I'd be thinking about a gram of either calcium chloride or 3 of calcium gluconate. And then continuing to resuscitate the patient. I suspect if they lost enough blood to go into a PA arrest, they're probably going to need some ongoing resuscitation beyond just the initial 4 units, particularly if they're on, vasoactive agents at this point to maintain their blood pressure. And then I'll sort of hang out there because there's some other work that I think we need to get done and start talking about the ventilator and
Sure.
stuff like that.
Yeah, I when I was reading this case, the couple questions that kind of came to mind is calcium as important in whole blood? We know that there's a lot of argument on calcium on like why we give it, right? We know that the PRBCs chelate the calcium, the citrate in there, but there's also an inotropic effect to it and the hypoglycemia. Is it as important in whole blood? If you're doing a whole blood resuscitation, is it as important or not? I'm just curious.
I think this is an interesting case because there's a lot to unpack, as we talked about earlier. Unfortunately, in Express Care, we have a couple of different arms. I just want to say a couple of things about getting out the door, because some of these patients need a lot more blood than you may be able to carry. And the advantage of him being an outside facility, especially in a program that at the time did not have whole blood, we have to be pretty thoughtful about what we bring. So I think, as Asa said, in addition to threading the Reboa up to his axillary artery, and I just had to say that because of our place here at shock trauma, but I think it's important to look at, some people need more blood than just the standard, certainly 2 units. And once we talk about that type of resuscitation, that's always the first priority, right? But once hemorrhage is controlled and once patients are getting blood, I think we have to prioritize the other intervention. And I think that's where sometimes in critical care we see these, we sometimes make it a little bit more complicated, right? If we look at all the patients that are dying due to traumatic arrest or traumatic circulatory arrest, they die due to exsanguinating hemorrhage, which we've checked. They died to mismanaged airways, which we've checked. They died of non-compressible pelvic, injury, check. I think also making sure this person doesn't have a massive hemopneumothorax, we can check that box. And then we really prioritize blood, then pressure, certainly calcium, TXA. But I think we're all speaking the same language, right? And with all due respect to our trauma colleagues, in some ways, I think from the transport perspective, it's kind of a simple equation. As you mentioned, Asa, it's about the very targeted and focused approach to the life threat, which sometimes means more blood. And then I think this discussion about calcium, I don't know that we're ever getting an answer. So my personal practice is that if somebody remains in hemorrhagic shock with ongoing hemorrhage, or you've given 2 units of whole blood, packed red blood cells, and it's clear that there's ongoing hemodynamic instability, just give the calcium, because at this point it doesn't matter. We're trying to save a life.
Yeah, no,
Sounds good.
I agree. We are so all over the spectrum with this calcium and TXA, like anywhere from, as soon as somebody's in hemorrhagic shock, I hear people that are giving calcium and TXA in a syringe and then giving whole blood, right? We are all over the map. And I think we have to be a little bit thoughtful about when we select to do these interventions. And I would agree with Ben that, hemorrhagic shock, 2 units of blood, they're getting calcium. They would have met criteria, obviously, for TXA, but it's not as simple as, somebody's bleeding a lot and maybe in shock and I have to give them blood. So I'm going to bang them in 2 grams of TXA and calcium as a chaser and then some blood. I think we get a little bit too, nonchalant about doing that kind of stuff. And there's real sort of thought that needs to go into it. Ruben?
Yeah, I think an interesting part of the hemorrhage control question is the blood pressure. Because I think outside, if this patient doesn't have head trauma, and I haven't really got somewhat, it sounds like, source control in terms of hemorrhage control, I'm not really targeting a very high blood pressure, right? I may be very okay with someone who is hypotensive. I know this patient coded, but now that we have a pulse back hemorrhage control, I'm not really targeting a MAP of 65. I'm not really targeting a systolic. Like, I don't want normal blood pressures. I'd rather live pretty hypotensive, keep the clot stable. And I don't think we talk about that enough in terms of hemorrhage control until we're going somewhere. So, I know that this patient is profoundly sick, but I think not being too aggressive with your blood pressure and trying to maintain whatever clot you have in that artery is also going to help the situation. I had a young lady many years ago who EMS brought in without a tourniquet, looked like you can look at the vessels in the brachial arteries, that you could see the brachial artery, and the thought process at that time, the patient got aggressive fluids and blood, and as soon as that blood pressure came up, that artery bled like stinking, and we had to use like two tourniquets. When if we would have just did permissive hypotension in this situation, which there was no head trauma, that clot would have probably been stable and been a much less eventful event, so. Good point.
Have you ever heard so much agreement between Hopkins, MedStar, and University of Maryland clinicians? I think we all agree that the thing that we're talking about is perfusion here, right? That's why in the absence of head trauma, as you said, we've really got to determine whether the patient is perfusing. I mean, I don't know what it's like on the east side of Baltimore, but unfortunately, our patient population, some of their baseline blood pressures are like 200s over 120. So this issue of relative hypotension is important, but I think all of our clinicians are very well qualified to decide what is perfusion, and that's the target, right? So whether that is the weak distal pulse, the patient remaining alert, I think that's a really good point to mention, is that we want to resuscitate to the fact that the end organs are being perfused.
Yeah, and I don't know that we've totally addressed all of the potential issues, in terms of a patient having PEARS, maybe we just haven't had the picture painted completely clearly yet in terms of where that blood truly went. Did it truly all leave out of an extremity wound? Or, one of the things that's going through my mind is, do we have an echo? Do we know what the heart is doing? Is the heart pumping? And while we have the ultrasound out, we're just going to run it down, make sure that the FAST is negative, make sure that he doesn't have any additional potential sources of bleeding. And that'll help guide our resuscitation a little bit more. But, I think that the two additional factors that I would also be, initially thinking about as soon as I'm walking in the room are, number one, what is his airway doing? Because I think that we've all run into patients where, they come in hypoxic and you crank up the PEEP, which decreases the venous return from all of the intrathoracic pressure. And then once you get that pulse ox up, people don't think about decreasing that PEEP, which will help facilitate your hemodynamics. And then the other thing, and I don't know if I just missed it, is what is our estimated time en route? Are we going by land? Are we going by air? Because it's going to make a big difference in terms of my resuscitation, if we are a 3-hour ground transport versus a 15-minute air transport.
In this case, actually, it was 20 to 25 minutes by ground, and it was at night, so there wasn't much traffic. Just for your information, to let you know.
I think to Matt's point, completely agree. It's concerning that, I don't know what the dose of norepinephrine was, but after 4 units and a wound that we have hemostasis on, we're still on norepinephrine, and we're doing push dose epi, it looks like here on this slide. Is there something else that's being missed with the patient where they're still hemorrhaging into another part of their body that either we don't have visibility on or we've neglected to think about because we developed tunnel vision with respect to this upper extremity wound?
Yeah, that was going to be one of my questions, is like, do we think maybe this giant whack on the guy's arm is somewhat of a distracting injury, right? Like, holy shit, he's got a giant hole in his arm, but we miss the fact that he's probably has an RP bleed because he got, Ian, correct me if I'm wrong, it sounds like this guy got the shit kicked out of him and thrown through a plate glass window, correct? He got beat up pretty good.
Yeah, all we knew was that he was thrown from an unknown height out of a plate glass window onto the ground outside. So there was, from the information we got from the ED, they said that he had the person whose house he broke into had a restraining order against him. So there probably was the possibility that he was assaulted before he was thrown out the window. So that's a solid.
We have some level of distracting injury. So from reading your chart, it looks like you guys gave 2 additional units of PRBCs.
Correct.
Dropped an IO. Created the levo
calcium.
infusion.
We did calcium pretty fast. Push dose epi.
The thing that kind of puzzled me was this guy's an AFib, correct? Do we have any idea if that was underlying AFib or that was what your chart had it written as, is AFib?
Yeah, no idea. All we could do was interpret the rhythm in front of us. He might have. He was in his 30s, and he might have had, but he was otherwise healthy looking, and he definitely didn't look like a chronically ill patient. But looks can definitely be deceiving, and you should never judge a book by its cover, especially when they're unconscious with a GCS of 3T.
For sure. So, did you have any improvement with your PRBCs? Or was it pretty much
actually
same?
There was some improvement, and especially with like the push dose epi and the norepi and the calcium. However, when we were en route, his pressure plummeted and his heart rate braided down into the 50s. And my partner and I looked at each other and we both said, "Oh my God, he's going to arrest." So we put the Lucas on him, didn't start it, and gave him a 500 milliliter bolus of normal saline, which is all we had in addition to the 2 units of blood from the sending facility. Additional units of blood from the sending facility, which were had just finished infusing at that point. So we got his blood pressure back up, and we could actually palpate at this time, which we had spent a few minutes trying to palpate blood pressure. That was distracting us. And anyways, we got him to shock trauma in a viable state, basically.
This
Sounds
scene was
good.
a bloodbath, pretty much. I could imagine there was a lot of conflicting issues when they found this guy outside with the entirety of his blood volume that was, he was in PE arrest. But I just want to echo what Dr. Sasser had mentioned. So these downstream treatments are predicated upon addressing all of the initial sort of life threats. And I mentioned that very briefly, but whether you have ultrasound or whether you're in, the fact that he's in an outside ED, we absolutely should have the visibility to understand and target the sources of hemorrhage that we can treat. So this treatment of, the diesel bolus and the giving of the blood, it assumes that we are going to look at the lungs for lung sliding. And I agree, whenever you have a hemodynamically tenuous patient without an obvious injury, that's an important point to underscore, because again, despite the 30 to 40 years of trauma arrest research, it's always the mismanaged airway, exsanguinating hemorrhage from the pelvis, the pericardial tamponade, hemopneumothorax, and that would be the responsible thing to do before we go in. And that's why I think all of our approach to these traumatic or peritraumatic circulatory arrests is not only aggressive and ordered resuscitation, but checking off all of those boxes. But I do think in retrospect, looking at the documentation from the dude that had a very bad day, that not only invaded a house, was put through the plate glass window, and then fell outside into arrest, it looked like he had exsanguinating hemorrhage from the laceration. And I don't recall, but I do think there was mention of no pericardial effusion on the FAST exam at the outside facility.
Also, I did a quick rapid head to toe survey, including palpating the patient's body from head to toe. I listened to lung sounds. I palpated the abdomen in the course of 30 seconds to a minute, and I checked for external hemorrhage, and none was found. I mean, I know that there's still the possibility he could have other internal injuries, but at least he did not have any other sources of external hemorrhage. And right off the bat, we made sure that he didn't have any other sources of external hemorrhage or injuries that we needed to take care of, in addition to his right upper arm laceration that was wound packed, that in any other case would probably be distracting.
Good stuff. Thanks, Ian. And I think you're 100% right, Ben. Like there's a lot to sort of unpack on this, and we can only do what we can do and kind of take it one piece at a time. One of the things that sort of the learning points or the things that I wanted to discuss today was do vasopressors. I mean, we gave this guy both push epi and he was on a Levophed drip. Do vasopressors have a role in hemorrhagic shock? And what is that role, and how are they best utilized? Do we have any idea what the best pressor is? Those type of things. Ruben, what you got?
Yeah.
I can talk about it.
Let's see. What does the evidence suggest? I don't think there's any evidence in the acute setting. And when I say acute, I mean pre-hospital, emergency department, transport, in terms of pressors and hemorrhagic shock. There is some stuff later on in their SICU course where, after being appropriately resuscitated, there's some improvement using pressors. But I think in our clinical setting, there's not a lot to go by. I think as long as you are filling the tank up, I think there's an argument for vasopressors. But obviously just using vasopressors in an empty tank makes no sense. So as long as you are resuscitating the patient while you're managing vasopressors, I think you can make a sound clinical argument to do so. Whether or not there's any evidence for it, yet to be seen.
Zach, what you
I
got?
was gonna say, this patient isn't just a trauma patient, they're also a post-arrest patient. So, you may have some degree of myocardial stunning that may benefit from like beta effects that you get with some of the pressors and
Sure.
other things. Like they're probably pretty acidotic. They may not be as responsive to their own endogenous catecholamines. So by really like slamming those receptors, you may get additional benefit from it. So I think, in a patient, like Ruben said, once you've done the resuscitation side, with your fluids in your blood and stuff like that, certainly if they may be pressure responsive.
And I think we're all in agreement that Levophed is probably the pressor, the IV infusion drip. But I've seen a lot of variants in different programs and different things for push dose, bolus dose vasopressor. Well, most everybody's got Epi. We've seen Neo, and then I know that I believe it's Air Methods uses push dose vasopressin in their trauma patients. Do we know if one is better than the other? I mean, my thought's always been that all Neo's doing is making the number look better. It's not actually perfusing because it just clamps down everything peripherally. But am I wrong about that? Is that be the better agent? Do we know the dosing? I've seen anywhere between 10 mics and 100.
See, there you go again, man, making it really complex with the traumatic rest. I think this vasopressin in trauma is really interesting to me. I mean, there was that one study, the AVERT shock trial, and some scattered stuff that talked about maybe boluses. But yeah, you can have functional vasopressin, but the bottom line is all about perfusion, right? So if you're giving blood and you have no blood pressure and circulatory rest, that's that one firm, angle of that triangle. So I think there is a role certainly for vasopressin. But as Ruben mentioned, when you're down this drain and you have somebody who clearly, I think in retrospect, exsanguinated from his arm, and again, I'm not saying that's the case. I am not a medical examiner. I think this guy actually survived. But you really need to maintain that perfusion. And whether that is push dose pressures as a bridge to something, whether that's vaso, whether that is epinephrine, I think the goal is we need to have a go-to in trauma that's not obviously supported by evidence, but something that actually maintains that perfusion while we're trying to replace that tank, because we don't have anything as fast, right? Even if you had your 2 large bore IVs with pressure bags, it's really difficult to replace somebody who's in this degree of decompensated hemorrhagic shock. So for full disclosure, this is my personal opinion. I would recommend that, as we did, you pay attention to the active ongoing hemorrhage with a crap load of tourniquets and staunch the bleed. But if that patient is still hypotensive while getting blood, I think we need pressors. And I think it's a very difficult decision in the setting of transport to figure out which one, because we just have to figure out something that maintains the BP. If you're with Ruben, it's going to be very permissive. If you're with Jeff, he may need a little bit more to perfuse his brain. So who knows?
Yes, sorry,
It's a very, very, but
I might have missed it. I just took a quick consult, but I think this is the one advantage of the Maryland model where everyone's available for a call. Like they want to be looped in on all this, and where the evidence gets gray, and you can defer to the receiving. I hate saying that because sometimes we get such garbage advice, but this is a time when the evidence is gray. I think this is what I've tried to harp on with our crews here. Just ask a targeted question. If you just present, I have this story, we're on the way to see you, they're not going to give you advice. But if you say, I'm an advanced critical care transport crew, I have 6 more units of blood next to me, I have these pressors hung, what would you like me to, what approach would you like me to take? Would more blood, more pressors, what map, pop the clot, not pop the clot? I think if you ask a targeted question, you'll get a better answer than how would you like me to proceed? No one knows how to answer that question. So in my mind, that is one of the advantages of having everyone so looped in. I think it gets very muddy very fast, but this happens to be one of the advantages in my mind.
I'm going to say this is a very, very difficult and dynamic clinical situation. And your decision is going to, I think, be moment to moment. I think it's a little bit easier if we have blood products and pressors to be able to work with both. And I don't fundamentally see a problem with that. Obviously, you need to perfuse the patient. And however you need to best do that, I think that's the answer. So it's not that, I have to fully resuscitate them with blood products before I can start a vasoactive agent. I think it's sort of the same way that we manage patients who are septic, right? We don't give them a total 30 cc's per kilo and wait for them to be, normal tensive before we start vasoactive agents. I think we start both and titrate off, hopefully, the vasoactive agent as we resuscitate the patient with crystalloid. Here it would be the same thing with blood products. I think it's a little bit more of a difficult question when we don't have blood products in the field, right? And we're just giving crystalloid. Do we just give them a whole bunch of crystalloid and hope that it eventually, gets their blood pressure up and refuses them before it dilutes them out? Again, I too think there's probably a role for vasoactive agents. As you resuscitate with some crystalloid, you can give some vasoactive agents to perfuse them to at least get them to a place where they can now get the proper resuscitation, which is going to be blood products. And then along the lines of push dose versus infusion-based vasopressors, I think push dose pressors are fine as a temporizing measure, but they really should be a temporizing measure. I think it's better to actually do a titration based on an inline infusion of a vasoactive agent. These are very sort of high stress situations. There's a lot more error that could be brought in when not only making up a push dose pressor, but bolusing or titrating a push dose pressor. And I think it should just be that bridge till we're able to get something up in line to allow us to then titrate with an inline infusion.
Dr. Staff agrees.
I think we're all on the same page. I mean, I think that, I don't think I'm going to add much more to this, the pressor question. I think that, you got to fill the tank. I fully agree that you kind of have to balance everything. And I fully believe that pressors are a good temporizing measure until you can get that tank filled. And I also believe that if you can hook it up to a pump on a consistent drip, that's going to be the best answer because it takes off that cognitive load. You don't have to worry about the push dose pressors when you get distracted by something else that you notice along the way. And so that would generally be the way that I would recommend handling it.
Yeah. And this gets back to the consult question too. So great job, lots of consensus here, but I think we can probably protocolize it. Just because there's no evidence doesn't mean, we can't figure it out. I also hesitate. There's a real good discussion about, I think Jeff mentioned it, we've alluded to it multiple times, medical control, because these scenarios, this person is near death, not only after he fell out or was pushed out and after he had his exsanguinating hemorrhage. So I think we need to have that approach. So in the midst of this, we're not figuring out, I wonder if on Tuesday, Matt wants to use, vasopressin, and Asa told me once he wants to use a little bit of norepinephrine. I think we can probably come up with a protocol that allows for flexibility and allows clinicians to really aggressively target this, because this guy, I think, was in the decompensated hemorrhagic shock, and that's a really tough space to be if you're not prepared, right? It goes back to the original discussion about preparation as well. It's a tough case.
One of the last things I want to talk about on this case, and then we'll move on to the next one, is what role does the ventilator play in management of this patient, right? So this is a hypoxic, or not hypoxic, but hemorrhagic shock patient that's post-arrest, probably acidotic from hypoperfusion. What role does the ventilator and how powerful is that effect if we don't ventilate this patient appropriately?
So that was actually one of the points that I was going to bring up, is that I think that the ventilator plays a huge role in patients like this. So I didn't actually notice whether or not we talked about the end-tidal CO2, but I think that we can all probably agree that this is a patient where we're not going to be aiming for an end-tidal CO2 of 35 to 40. We're going to want that end-tidal CO2 being blown off as much as possible, because that's going to help restore the patient's acid-base balance. I think that after a PEA arrest, I agree that they're going to be pretty acidotic. We need to increase that respiratory rate. I did see that the PEEP was down at 5, so that'll decrease the amount of intrathoracic pressure as opposed to a higher PEEP, and I think that's great. But I do think that ventilating a patient appropriately is going to play a significant role in resuscitations like this. Did we have an end-tidal CO2 on this patient by any chance? And were
It was
they
in the
above
low
vents?
20s on the chart.
Yes. Yeah, it was 22 and 23 respectively, without any kind of change in the ventilator settings by us.
And they were breathing
And
with
I
the
always
vent,
work.
not above the vent?
He
I'm
was
sorry?
riding the vent, correct, Ian?
What's that?
He was riding the ventilator, correct? He was not over breathing.
No, he was not overbreathing.
I always worry about end tidal in these type of patients just because it can be misleading because of the VQ mismatch and the poor perfusion. I know I've seen some cases where people have literally turned down the minute ventilation goal because their end tidal was 23 and they're like, oh, we're overventilating them. So that's my only worry with end tidal sometimes. And I think that's something that we need to make sure that we educate folks on, that end tidal is a great way to confirm the ET tube's in place. but it's not a measure of their, or it is a measure of the perfusion, but you have to know how to interpret it. So do we need to run at the risk of essentially increasing this guy's interthoracic pressure? We need to run a higher minute ventilation. Would that be sort of the consensus for the group?
Yeah, I would run him on a higher minute ventilation, and I use rate to do so, less so of tidal volume.
Less so a tidal volume. So keep the tidal volume on the lower end.
Tidal volume on lower and lung protective ventilation. He's a setup for potentially ARDS in the setting of trauma and whatever else is going on that we have no idea about at this point. And he seems to be oxygenating fine, so we're okay for there on the PEEP.
Yep.
So I would just give him a higher minute ventilation and use your respiratory rate to be able to achieve it.
Okay. Sounds good. All right. Any last alibi fires on this one before we move on to the next one?
By car.
Just to mention ASB, I want to make sure he has a pulse despite his end title of 28.
Sure.
Yeah. How about some bicarb?
Thank you.
Also, may I say something? So one of my concerns with this guy was hypothermia. So in the setting that we were in, I'm not, besides throwing warm blankets on him, I'm not sure what else we could have done to improve his temperature, but hypothermia being part of the trauma triad of death, so to speak,
Rhombus now.
was there anything that maybe we could have done differently for hypothermia, or maybe that critical care transport programs can do differently to like temporize hypothermia or start to temporize it in the field so that patients don't get more hypothermic than they already are? Because this guy's skin was very cold to the touch, as to be expected with a trauma patient like him.
It's a great point. A couple of thoughts. So yes, we tend to neglect that because we're so busy doing other things and making the patient trauma naked that we forget to, cover the patient up. So not only the blankets, but I think the temperature in the back of the transport unit too, right? Like the temperature in the back of the transport unit is usually kept for our comfort. It really should not be. It should be kept for the patient. And what the clinical situation is. In this case, we really need to increase the temperature in the back of the transport vehicle. And the other thing is, I'd be curious to know whether or not a blood warmer was used when getting these 4 units, because obviously, we're taking cold blood out and we're giving 4 units of blood. This is where we could tend to see a drop in somebody's core temperature by giving them effectively cold fluids. I'm not quite sure how much, we would see with one 500 cc amount of whole blood, but by the time you're given now 2 liters of it, it could be substantial.
Yeah, unfortunately, I don't think any kind of warmer was used at the outside facility. And unfortunately, our QuinFlow or QinFlow, however you pronounce it, was out of service at the time. We do have a working QuinFlow at this time, which we use regularly. However, unfortunately, between us and the sending facility, one was unavailable or not used.
We're following the New Orleans protocol.
The Meg Marino New Orleans protocol.
Right, just give them the blood.
Just give them the blood.
It's sad. I mean, we try to be a high performing transport program. The reality is that this program went from 0 to 60, I think, very fast. But I want to echo that I totally agree that the goal should be to warm to the extent possible. So, the blood warmer should certainly be used. I think that you talked about blankets and being mindful of not exposure, but that is the current practice. I mean, there is an ongoing debate about how necessary is it, but I think I would argue that it probably approaches the standard of care to try to warm the blood if you can, especially for a patient in this degree of extremis.
For sure. All right. Thank you, Ian. We're going to roll on to this next case.
Thank you.
So case 2, brought to us by our good friends at Express Care 1 and PHI. Ryan and Katie have this one. So they get tapped out for a 63-year-old male, 75 kilos, multi-system trauma, had a motorcycle versus car, vented, multiple drips. So that's sort of what we got. Ryan, Katie, I'll let you guys kind of give your initial presentation and tell us what you guys found, what you saw.
So first off, thanks for having us, and thanks for that what appears to be a very old picture of 329. It's not even decaled in it. So we get down to PRMC. The guy's in a trauma bay. That trauma bay right down the end of the hallway. Clearly had been a very festive resuscitation. So we get there. Big thing we noticed was first, he was kind of climbing around, getting up out of bed, breathing about 40, 50 times a minute. His vital signs were okay based on how we found him, but he was agitated, completely dysynchronous with their ventilator, and clearly in a lot of pain. So, did you want me to go over the backstory or just kind of what we saw when we first? That's what I first noticed.
Yeah, no, go ahead and give I kind of pulled the ED course out. You can kind of hit the highlights here, and sort of what they were seeing, what you guys were seeing, and kind of paint the picture.
Okay.
Of course.
And the reason that's an old picture of 329 is because I'm OG Express Care.
I believe this also happened at shift change. So there was the classic, I'm not sure where this tube is supposed to be, the chest tube, coming in and out, like all these repeat trips to CT scan, and no one really knew or was completely sure of anything. So that contributed to some of our fact checking in our troubleshooting.
Yeah, and for context, this guy he had been there for quite a while. So he got hit by, this was at like 10 o'clock at night or 9 o'clock at night. We're doing all this. He had gotten hit by a car about 4 o'clock that afternoon. They tried to fly him from the scene, but it got turned down for weather, so he got driven to PRMC, and then he had been there. So we're like 6-ish hours into this guy's hospital course when we finally put hands on him. So basically, he was a motorcycle driver, got mashed by a car, came in, got intubated. Once he got to PRMC, they found a big right-sided tension pneumo that they put a chest tube in. A couple trips to and from CT, but notably, we specifically asked, none of his imaging was reflective of hemorrhage. It was one of our first questions we asked when we got there.
Okay. So they are side him, they get him on the ventilator. One of the things that I wanted to highlight on the ventilator, and this will become like a little more important as we go through, is even when you guys found him, right? Minute ventilation was poor, tidal volumes were garbage, even breathing 40 times a minute, you're getting a minute ventilation of less than 5. And like you had mentioned, there was a massive leak in the chest tube. And of course, neurosurgery wanted the Versed DC, because God forbid they not be able to get their neuro exam when we show up. So why don't you, so you guys get there, you add ketamine, you get them on your ventilator, and we'll get to the sort of vital signs and sort of what you guys did kind of chronologically here in a second. But one of the things that happened is you guys clamped the chest tube, right? And you had a massive jump in your tidal volume. Is that true?
Yeah, that was true, but that was pretty far down the line. Like that was probably, we had troubleshot some other things first before Kate brilliantly thought of clamping the chest tube.
Sure. You guys were concerned about airway placement, correct? So you requested a chest tube, or not chest tube, chest X-ray?
Like changing shift, they were arguing about where the tube was actually supposed to be, and the patient had just gotten back from CT. So I was thinking, if it looks like a duck and it sounds like a duck, that's probably what it is. So then once it wasn't, we were just trying to scramble and figure out what was the problem. So
yeah, because in addition to the bad VTEs, we were getting end titles in like the single digits.
Okay.
This is official all over it.
All right. So you guys add some ketamine appropriately, right? Breathing. This guy's crawling out of bed, breathing 42 times a minute. Blood pressure is good. Heart rate's okay. Sats are good. You add some ketamine, and then you're talking to the sending facility. Is this guy's airway in? Right. You get that chest X-ray. Start talking about that. Right. So, and like you said, your end titles are in the single digits. So what are you guys thinking here?
Yeah, our first worry was I was worried that tube was kind of just sitting right on top of the cords, like maybe the balloon had backed out past, so maybe just like the Murphy's eye is sitting through the cords. So our first troubleshoot was like an airway displacement. So a little bit of after a little back and forth, we were able to get a chest X-ray that showed us it might have been a little high. The tube was a little high on X-ray. It was kind of hard to read because he had so much air in his chest. But no, the RT still pushed it in about it. They put it in another centimeter. They pushed it down to 25 centimeters, the end tidal waveform. I think at that point, the numbers jumped up to like the teens to low 20s. So we knew we were in the right spot. We knew it wasn't the tube. We checked, we checked the cuff pressure. It wasn't a cuff leak. And then that's when Kate clamped the chest tube and to the VTEs on. He's back on our vent. So we tried to put him on our vent. We were like, this looks terrible. Put him back on theirs. This was the point where we realized their vent was doing the same thing. We just in the chaos of the couple 5 minutes, we didn't really notice too much of what their vent was doing. But once he did it on our vent, we put him back on theirs. He did the same thing.
They had their
Did-
alarm parameters set
right.
way low.
All their alarms have been silenced. So we did some troubleshooting, and then that's when we realized we were just dealing with a super leaky lung.
Good deal. So we can kind of see the blood pressures and vitals here. So you guys ended up clamping that chest tube and seeing a massive jump in your tidal volume. So big leak in the lung, chest tubes sounding like a jet engine on the floor, right? Confirm ET2 placement. And this is I was able to somewhat recreate what you guys were seeing on the ventilator. Is this roughly what you guys were seeing? So a max leak compensation alarm, low peak airway pressures.
Our numbers were way worse, but yeah, our initial VTEs were like they were like 80 something, but yes, 80s, that's what we put in the vent.
It's because I could only get it to leak at 60%. So, but you guys said your leak is closer to 80 or 90%, correct?
I think at one point it was like 95.
Okay. So my question to the group is, what the hell's going on? I call you and I'm like sending you pictures of this ventilator. What in the world? What the hell?
Sounds familiar. There's a disruption somewhere. You know, you have to start thinking about, you know, large bronchopleural fistula. You know, you're unable to measure end tidal because you're losing the ability to ventilate the patient because all of this stuff is going out somewhere. And that's sort of my first thought. I totally agree and applaud the crew for being very systematic about how they approach this. You know, even though there are a lot of things here that talked about that talked about or that led us to believe there was a large air leak, I think you have to rule out, you know, malplaced endotracheal tube. You have to run your equipment. You have to do all the typical things that we think of when we use the A-dope or the dopes or whatever mnemonic you want to use to troubleshoot, you know, decompensating patient on a ventilator. But after that, you're starting to think about, you know, large air leak, loss of end tidal, inability to ventilate the patient, low minute ventilations, that there's probably some disruption in your airway. Ruben?
Yeah, it's fascinating. What did the X-ray that you guys got, was that after or before clamping the chest tube? And what did the lung look like on that side of the chest tube?
I'm sorry, can you repeat the first part of your question?
The chest X-ray that you guys got after the ET tube was repositioned, was that done? That X-ray, was that done after or before the chest tube was clamped?
Before, because that was our troubleshoot. That was us checking the placement. So it was before we attempted to clamp.
And when I said that I clamped it, it was like for maybe 15 seconds. It didn't remain clamped for a significant period of time, just long enough to see the VTEs come up.
Well, interesting. And then when you unclamped it, they stayed up?
No, they shot right back down.
Oh, okay.
I just wanted to prove to myself where the air was going.
And then what did and I'm assuming the chest tube site, the actual insertion site, was well dressed and all that?
Yep, we actually took the dressing down to make sure that all of the fenestrations were inside.
Yep.
And he had crepitus all over his chest, like all over both sides of his chest.
Okay, very interesting.
So
Subcutaneous emphysema, Ruben. We're waiting for you to say it.
Subcutaneous emphysema, you want me to say that?
The chest X-ray was kind of hard to read. There was so much scattered air in the chest. It was kind of it was not that. I mean, not that I'm good at reading chest X-rays, but this one was particularly difficult to find all the landmarks.
I just want to mention too, I think you're hearing a lot of common troubleshooting themes, and it's appropriate, just like we did in the first case when you were presented with all these simultaneous life threats at the same time. This is a very difficult call to analyze here, and we will let this thing play out, obviously, because it's a very interesting call. But how do we direct our troubleshooting? And a lot of that's predicated, I think, as you said, Asa, on the assessment, right? So in this case, we have to run through a very brief but targeted checklist in terms of what can we fix. So I think the systematic approach to something like this cannot be underestimated. Make sure the tube's in the right place, make sure the tubes and all the fenestrations are in, make sure there's no leak in the actual circuit, and figure out, what we can fix. Because then if all that is okay and it's not a ventilator problem, then we have even more decisions and it gets more complicated. But that's how we kind of have to run down the line. And I think in both of these cases, there's a very similar theme of this critical decision making. We're not getting lost, but we're answering, I think, very specific questions so that we can target our downstream therapies. And even though all of us can look at an X-ray and look at different things, I think it is really important to note here that we clearly have a leak in the system, meaning in the person, right? Because this issue of the bilateral subcutaneous emphysema and this patient's presentation would suggest there's some internal disruption, as you mentioned, Dave. So I love that highly scientific diagnosis. But I just wanted to call out the systematic approach to this. That's a good lesson learned for all of these cases.
Absolutely.
And it's interesting that I think there's a trap, and you clamp this thing, and you're like, oh, I'm getting my volume back. Let me just keep it clamped.
Ooh.
And yeah, I could definitely see that being something somebody does. And
wait. So are we LOLing because I because I proved to myself and then just left it unclammed and I should have left it clamped, or you're relieved that
We're
I
laughing because
no.
it would have gone really badly had it
that's
been left
actually-
clamped.
Okay,
Yeah,
that was my understanding of it too.
Yeah,
I just
you're
wanted
right.
to make sure. I'm like, am I the idiot? Like, what?
No, that was fantastic. I'm saying that the trap is, you clamp this thing. Oh, my numbers look great. Let me keep. Let me keep. That's what I'm saying. It's like there's such a large trap to fall into that. So no, I'm saying
I'm
excellent
blonde,
job.
but not quite that blonde. I got brunette roots, so it's okay.
And also, good job sedating the patient too. I think that's, when patients have these large bronchopleural fistulas or large air leaks, I mean, you need to appropriately sedate them to allow us to do whatever we can and the ventilator to do whatever they can for the patient. So wanted to highlight that as well. So I thought you guys did a nice job
So
there.
now we've established that there's a leak in the system, one that I can't fix externally, right? So what is the strategy? Dr. Torrey, I think you're our airway ventilation expert, if you will, as an anesthesia provider. What are we doing? Like, what can I do? Can I do anything?
From what we do, it's typically what I've done in this situation is try to do one lung ventilation. Knowing what happened in the OR to this guy when they did one lung ventilation, there's always that risk. Obviously, you don't have a bronchial blocker or double lumen, so I will just main stem it either right side or left side, depending upon what side I can put the tube or what the issue is. So I don't know if that's what you guys do, but that's what I will do in the OR if I don't have the option of a double lumen or a bronchial blocker. And we know we have a bronchopleural fistula.
So I guess my question, having heard that, that's the fix. So to the medical directors that are on here, is there a conversation to say, wherever I'm at, if I can get anesthesia to come, put a fiber optic scope down there and left main stem. This guy was his right, correct, Ryan? Okay. So do I call anesthesia or find an anesthesia provider somewhere as Ben hides to left main stem this patient? Is that worth staying on scene and essentially getting this taken care of potentially? So Arissa's even shaking her head no.
You're never going to get an anesthesia provider down there, and you don't even need a fiber optic. If you need to main stem it, you can, but at the same time, again, that's what I do in the OR just to temporize, and I've got a surgeon there fixing the problem.
Sure.
So I wouldn't say that's necessarily the best thing to do on transport, because you're just going to get yourself hosed from a VQ mismatch at that standpoint. But I don't know. I know Ben's hiding over there. You'll never get an anesthesia provider down in the ED.
Yeah, I don't know how everyone else's emergency departments are. I can sometimes get an anesthesiologist, but it's definitely not going to be quickly. And the fact that it's the right lung that seems to be blown out, and we would have to put the tube down the left, that's going to be a lot more complicated. I mean, we do have fiber optics in our emergency department. I don't know that everybody does, But I can tell you that most of our emergency physicians would not be overly comfortable using that fiber optic to try to left main stem and intubation. So I guess the question is, if you can do that, awesome. If you have anesthesia, awesome. But I think that we're kind of operating in the under the assumption that we don't have that as an option. So then I'm going to come back to, okay, well, how far am I from, our ivory tower? How quickly can I get there? And, if I don't have any other options, are we going to temporize this patient by intermittently clamping that lung or clamping that tube to just get a little bit of tidal volume to get them a little bit of ventilation so that they actually are blowing off some of that CO2? I don't have a good answer for that because I've never run into this case, but I think it's an awesome case. And again, kudos to the transport team for troubleshooting it the way that they did. I think that it was very systematic, and every time I wrote down something to think about, they immediately checked it off the list. And I'm like, okay, well, that's not it.
I want to also call this. So this is a great discussion, right? Because I think it's also telling that we've all been doing this. There's a lot of collective expertise here. And, we got way into the weeds after this debrief with the anesthesiologists and the surgeons and the ECMO specialists and the left lung lingual fellows over at Shock Trauma. And the bottom line here is that, can we transport this patient safely? And I think Jenna McGovern, one of our other flight nurses, said something very interesting in the chat, right? Because this is a very difficult place to be, and we owe it to ourselves, again, to think about options, right? So can we transport the patient safely? Remember that this patient had a very large leak. There was lots of emphysema in the chest, but we could get chest rise and oxygenate. And I think that is a critical point of this because as Dr. Sasser had mentioned, this gentleman needs fairly aggressive and specialized therapy that we may not be able to do, right? If this is another academic center, absolutely we engage our consultants. I just don't think that for the majority of transport programs, this kind of decision of should we selectively do one lung ventilation is a good temporizing measure initially. So I think fortunately, we were able to assess the patient's oxygenation and chest rise, which though suboptimal, was able to at least provide some degree of, ventilation. So just wanted to call attention to that comment in the chat, but we should talk about what are the definitive options, because this case, if they did not get that, we would have been, again, right back to that difficult Erissa's question, which is who knows what we do, and that's going to require some discussion.
So you guys decided to not necessarily forego that, but you didn't have an option to left main stem this patient. So you guys loaded up and headed out like the transport teams do, right? They die here, they die en route, they die, like we got to do something to get them from point A to point B, right? That's what our job is. So you guys loaded them up, threw them in the helicopter and headed for the house, right? So give us a rundown of, I kind of summarized what you guys did en route, and then we'll jump into sort of how it played out chronologically with vital signs.
Yeah. So we left them on the same bed settings that you mentioned earlier. The linchpin to us for the whole thing was he was able to oxygenate, right? So we had sats of 98 to 100%, and so interesting with this guy is we treat him like a bronchopleural fistula, but the thing is his injury is to his lung parenchyma. So maybe the way this was working in my head is if like the gas can go into the lung and then it's going to leave the lung, but it's just not coming back to my flow sensor. Like if I had a theoretical flow sensor inside his chest tube, the two flow sensors would probably add up to what he's supposed to be getting. So I'm like, okay, well, it's going in and out somehow. Otherwise, because if he wasn't oxygenating, he wouldn't have made it the first 6 hours. So we put him in the aircraft. We converted him over to a ketamine infusion just to alleviate some hands and some task load. And vital signs did okay, did okay in transport. His end titles and VTEs crept up, so end titles were in the 20s. And his VTEs made it as high as I want to say the low 300s throughout the trip. The Hamilton was giving us the max leak compensation alarm, but maybe just through being an ignoramus, I'm like, well, sats are okay, so I'm just gonna let the vent do its thing and max leak compensate. So the flight itself was somewhat uneventful.
Okay. Yeah, it looks like you guys gave another ketamine bolus some crystalloid for a little bit of hypotension, marginal hypotension. Started that ketamine drip, gave another bolus, and then you ended up giving an epi bolus a couple minutes out from trauma before you hit the deck, just
that was in the
hypotension.
That was in the penthouse at like every.
Oh, okay, that was actually on the roof.
Yeah, always happens right.
Gotta make the numbers look right, or the truth's gonna get angry at you, right? Why'd you bring me a sick person? So then you transfer to the true. So I guess my question here is, and Jeff, I'm gonna poke you. ASV would have been a horrendous plan for this patient, correct?
I wouldn't be recorded ever saying ASV is horrendous. So let's just cut that part of the audio out.
Fair enough.
I think it would have just errored out the entire time. It would have never reached its tidal volume. It would have just been, it gives very low volumes. ASV takes a number of breaths to start building, so it would have never moved out of the building phase. So ASV would not have been the right mode here. I think basically any of the other modes where you're telling the ventilator what to do would have been better. I'd be curious actually what would have happened with ASV, just because the leak is so unpredictable and you guys were doing manipulations. But I agree, ASV was not the right choice here. ASV is never horrendous, but it was not the right choice. I also think to Dr. Torrey's point, this is PRMC though, and like obviously, the calculus is different everywhere. You come to Midtown, the Stabilization Center of Excellence, you have to just leave. We have no help, no one's coming, nothing's happening. PRMC is a level 2 trauma center that's very, very remote from other people. It's not like they just punt people down the road. They do a whole lot of stuff there. It's hit or miss on what day they're doing what, and technically by the books they have a lot of stuff. So I think it's important to recognize, if you're at a very small community hospital, you must leave. If you're at a level 2 trauma center, I don't think it's unreasonable to ask for an anesthesiologist to come and assist in this critically ill dying patient. I think by state definition, they must have someone on call. I'm sure someone was involved with this case. I don't think it's unreasonable to ask anesthesia to come and assist, but I certainly don't. It's not my practice to bronch people and left main stem them. I'd love to try in a sim lab any number of times. I'm now inspired, but I think that just don't forget, PRMC is a level 2 trauma center.
Agree.
Sounds good. Is there value in getting point of care labs on this patient or having PRMC draw a gas for me? Or is that just a waste of time? It's not going to really add anything to my my plan of care. Since we're not really getting end tidal, we can assume the guy's oxygenating well, right? We had good sats. Is there value in getting ABG, VBG to kind of quantify where we're at from an acidosis standpoint, and mostly a CO2 confirmation?
No. For me, not really. I don't know
Okay.
what to do with that information. Like I've been able to maximize the patient the best that I can at this point. Again, they're oxygenating. I'm ventilating a little bit. Don't really know how much, obviously.
Okay.
But there's not any additional information that even if I get it, I'm gonna be able to do anything with.
Okay.
So we should just boogie.
Just boogie. Okay.
I think this is also another discussion before they get to the ECMO Center of Excellence here too. So if we're thinking bronchopleural fistula, and this is going to be Dr. Torres Rojas as well, there was a lot of interesting stuff we talked about downstream, but I'm still stuck on this issue of, do we introduce more variables? So Jeff Nussbaum said something important. They're at a level, they're at trauma center. We can talk to anesthesiology there, but in my experience, and even at a lot of places, they've already made the decision that I don't believe they move the patient to the ICU. They want to go. However, we definitely need to ask. The question though, before we leave is, can we optimize our vent settings? And I think this is a really interesting question here, right? So it'd be interesting to think about what ASV would do, but is this a case where, the Hamilton is essentially a pressure regulated vent, right? Is it better to look at a volume control and stay there if you have a leak that's failing with the maximum leak compensation? I think that's a really good question because our toolboxes are limited. One of the things that anesthesiology suggested is that you can just set a higher, volume target, realizing it's a pressure control vent, just to initially get some more tidal volume. But that is a good discussion to kind of have before you leave. Are we doing everything that we can? Have we engaged all of our resources? Because I think the other pitfall would be looking at different modes of ventilation, especially in a very dynamic situation like that. So I don't know. I think that's another question that remains to be answered.
I've actually got some answers on that I'll talk about here in a second. Just because I am the ventilator nerd that I am, I played around a little bit with this.
You're the best compliancing this guy.
Yes, exactly. People best compliance all the way. So I guess my question is also, where do we think this guy's hypotension is coming from? Right? He's not bleeding to death, right? We ruled that out. Why did he become hypotensive? He's oxygenating fine, so it's not not a hypoxia thing. Could this be a result of the fact that we weren't clearing enough CO2 and we had some level of acidosis building? And then how do we mitigate that? If we can't ventilate them better, is this the case where bicarb makes sense? I'm gonna crawl under the table now before somebody starts throwing things at me.
No,
Yeah.
I find this case incredibly difficult, obviously, because of what's going on, but even to manage this, I don't even know what numbers are reliable.
Sure.
I don't know what this volume is at all. I don't know if that's just what's going into the thorax, what's actually going into the lung. I have no, other than the respiratory rate and the oxygen saturation, I don't know how to interpret any of these numbers given the clinical scenario. So I don't even know how to mitigate things unless I just go to the operating room, right? I don't, no, seriously, you could give me an ABG and okay, it gives me the gas, but I don't know how to manipulate the vent because I don't know what any of these numbers mean. I don't know where this volume is or what it's
Fair
doing.
enough.
Agreed. I think completely agree, and I think we have to do what we can to not make this worse, right? So not reflexively turn up the tidal volume because we're not getting tidal volume. I think that's a fatal error that we make, right? We look at our exhaled tidal volume and it's 80 or 122, and we're like, oh, let's give them more, right? That is a fatal error. We want to do lower tidal volumes in these, whatever, if this is a parenchymal disruption or bronchopleural, whatever it may be, right? You want to give less trauma to the lung. Luckily, we were oxygenating okay at a PEEP of 5, but had you had to go up on the PEEP, another fatal error for these patients. And the other thing, ideally you'd want to do is actually decrease the eye time, again, to sort of, not further traumatize what's going on. So I think, there could be a lot of different places we can go wrong on this case. And I think going right is really recognizing that we don't have reliable numbers. We probably can't do better than what we're doing now. The patient is okay, so let's just go and get them where we can get them so they can have done what they need to have done.
Sure.
Yeah, Beth has a great question, is that this is where the consultant process is helpful, because I think we all agree, yet again, right, this is the other theme of consensus, is that we're talking about clinical targets, right? At some point, we have a decision to make based upon a patient that is critically ill. And even though this is a level 3 trauma center, it is fair to ask the question. In this case, however, PRMC did not have the resources given this leak. There was a talk about ECMO and thoracic surgery, is that in this patient that was decompensating, they had made that decision or determination that, it needed to go to a quote unquote higher level of care. But I do agree that we should always ask the question, right? Because to Jeff's point earlier, as a trauma center, there's a lot of things that can happen in the OR. I guarantee you there's probably 1 or 2 anesthesiologists that may be looking at selective lung that are hanging around. So we just have to make that decision with all available kind of facts to the best of our ability. So it's always good to answer the question, but I think in this case, the decision was made. Don't forget, he also had neurosurgical injuries, multiple complex orthopedic trauma. So this was a case where they had said, risk benefit, they should go, and they had reached their limit of stabilization. But that limit is definitely dynamic. And as we've seen in both of these calls, it evolves.
I think that is something that we were considering was, the time sensitivity of his head injury, as well as, of course, not reflected in the chart, but the weather at the time was also something that I know that San Galvano was, gave us a little bit of feedback on this, as well as the possibility of having the Go team as a resource. But I don't think that would have been a realistic resource on that particular day for that particular patient. Just because of the weather considerations.
Yeah, this was like a marginal. We ended up doing a bit of, actually had an IFR leg on the way home, but we were not super time crunched, but we were trying to avoid having to we made arrangements to get over, because we don't have an approach to PRMC. So we made arrangements to get over to the airport to leave IFR, but we were trying to hope to avoid that if at all possible. So there was some degree of a time element to try and mitigate all the hurdles of having to put him in a ground ambulance that our stretcher doesn't fit in, and so on and so forth. So there's a bit of we did have a bit of a perceived time crunch in this particular flight.
Yeah, the Go team would have been interesting. Jeff Nussbaum and I would have gotten there, and we would have been like, we still need to leave. That's a good, right? Hey, you get what you pay for on the Go team. It depends. I mean, we could have, that's a great point. but I think it's
I would have loved that confirmation at the bedside. I would have loved that.
like and then I would have called Tom Sklade. He would have sent somebody to drop out of the sky on the Maryland State. We haven't mentioned Maryland State Police yet. So for the record, with them, we've already hated on ASB. Maryland State Police would have come, transported the whole ECMO suite. That's another option we failed to consider.
For the ECMO suite.
Over here. And a Revell ventilator.
There were ventilator. Yep. So I guess my last question here is like, this is, and I'll talk about sort of what I discovered with the ventilator. This is probably one of the flaws of the PRVC, whether it's ASV or SCMV on the T1, is that for some reason it won't turn up the pressure, right? You could have turned up your tidal volume to 800 cc's and it wasn't changing anything because of that max leak compensation. When I played with it, I kept turning it up and it wouldn't go any higher than about 19 or 20 on, it essentially capped its pressure limit out at 19 or 20, even though the pressure limit was set much, much higher. So what I discovered, and whether this would have actually worked, and to your point, Asa, who the hell knows if these numbers actually matter or what they actually are, but I switched them over into a straight pressure control ventilation and put it at 20/5. So for a total of 25, and I was able to get tidal volumes up to almost 500. Just by putting them in pressure control ventilation and essentially overdriving the leak. So we're not really at a super high pressure from that standpoint. Let me close that. So this may have just sort of learning points, and whether this matters or not, or whether it actually would work, who knows, right? Because I wasn't there, but this worked on a test lung with essentially the leak plug pulled out of it and a 60+% leak. So this was at 0.8 where you guys had your eye time, and by turning it up to 1, I was able to get it up to almost 600 cc's of tidal volume by just extending out the eye time, and essentially overdriving the leak. So what are people's thoughts on that? This is on a test lung, so it's a very fake situation, but I was able to play with the ventilator on a test lung and essentially overdrive the leak.
How did you figure out the leak on the test lung?
Say again?
How did you deal with the leak on the test lung? How'd you
We
make
have a test lung that I can essentially leak at apparently up to 60%. Yeah, 60%, because it's got a plug in the side of it that I can just pull out. So I was able to make it leak in a massive amount, and it's interesting because the CMV wouldn't go up any higher. It gave that max leak compensation alarm, and then it wouldn't go any higher. But you turn it into a straight pressure control ventilation, and it just keeps going to whatever you told it to go to.
That is interesting. I never would have thought that would actually compensate for it, because I know that the Hamilton uses 60 liters per minute as its maximum velocity. I would have thought that it would have compensated even in CMV, but that's very interesting. I wouldn't have thought to go to PCV plus to try to override that.
I would not have.
I have to talk to the Hamilton guys to figure out what it is, but I think honestly it looks at VTI instead of VTE, and it looks at that as the goal. And if you're leaking at 600 cc's, it thinks that it met its goal, or it's basically trying to be safe and not overpressurize the lung with that big of a leak, because it doesn't know what it's actually seeing.
Yeah, that earlier too, but then what about the other concern is the physiology. We didn't know where exactly the leak was. I mean, I'm sure we can narrow it down. He's already got significant subcutaneous emphysema. And then I think the other concern is worsening a pneumothorax. That's a really good question, Sam. I don't know. I'd be interested to hear the group's thoughts in terms of PCV and looking at VTI. I don't know that I would have thought of that.
I agree with everything that's been said. I think in this patient, if they were oxygenating and hemodynamically stable to the point where like the acidosis that is being created from the inability to ventilate is not harming the patient, I don't know if I would it looks like it's working, but I don't know what the sort of downstream trauma effect on the lung is, and whether
I'm blowing a shit ton of air into their chest.
You're just blowing air in the chest, and whether that's volume is actually being used to ventilate the patient. actually do ventilation versus just sort of fill up the
I mean, that's
cavity.
return ventilation, so that's air coming back out of the ET tube, right? That's the flow sensor picking that up, coming back out as negative flow.
Yeah, but whether that's actually doing, you know, I don't know
Yeah,
where the
what that's
injury
actually
is,
doing,
so,
who knows?
yeah, if that's helping with gas exchange, I guess is the point.
I mean, I agree with Asa. I agree with what you guys are saying. The other thing, thinking about the emphysema, like you start getting it tracked, I know it tracked up his neck. You have to start worrying about where's the air going, and then hemodynamics. He's already hypotensive. Where's the air going? Are you going to worsen your hemodynamics from that standpoint? That's the only other thing I would consider when you start trying to target that high of a VTE.
Regardless, this is a tremendous thought experiment, and I commend your nerdiness. I really do appreciate it.
So
It's great. Yeah.
just. All right, so thank you to everybody. I really appreciate it. Thank you to the folks who presented. It's never comfortable to get out there and throw your case out in front of a whole bunch of folks and have to hear people Monday morning quarterback it. So thank you to all the folks who presented, and then thank you to the panel for your thoughts on anything. Any last thoughts on any of the cases? Anything anyone wants to throw in? We got about another 5-7 minutes.
Yeah. Did you want to do
outstanding work?
Oh, go ahead.
Go ahead, Ben. No, I was saying outstanding work to the crews. I mean, both of these patients would have surely expired had they remained at where they were. So great job, tremendous kudos to you guys. You did something that most people would not be able to do, which is take a previously dead and dying patients and get them to where they needed to be. So and probably got them there better off than, you know, when you left the scene. So good work.
Yeah, and Asa, credit to you and all of the organization. I know we exchanged a lot of good-natured ASV ribbing, but thanks for your pursuit of the transport medicine excellence. You are our partners in all of that. I just wanted to give a couple words of follow-up on this patient. I think he was discharged to rehab at a significant TBI, but and I know if I'm not, correct me if I'm wrong, Dr. Corbett, that I don't think the source of the leak was ever found. They tried a bunch of occlusion tests, but it was probably due to the nasty, just messed up lung parenchyma, but I don't think the definitive source of the leak was ever found. But just be mindful of the destination, because this patient may have required ECMO and sort of advanced interventional pulm. So I guess as good of an outcome as could have been desired.
Marissa, you texted me, you had looked into this, and he got hypertensive when they blocked him?
Yes, so he was actually satting 100% when they brought him down to the OR. They paralyzed him, and that's when, and tried to do positive pressure ventilation. That's when he desatted. They thought it was a chest tube. The leak actually worsened. Team was called in. There was no improvement. Then they tried to do a bronchial blocker, and he became hypertensive. SAPS dropped to, on the chart, it was 80s. The downside is that you can't see anything. The chart itself didn't record any of the vent settings, so you can't see the end tidal, you can't see what the PIP was, you can't see the mean airway pressures, so you could only see the hemodynamics. But it was interesting to see hemodynamically what he did, and then when they came down with the bronchial blocker, his blood pressure dropped, and then SATs improved, so they canceled the case at that point in time, and he couldn't come back for almost 14 days, I think it was. Ben, tell me if I'm wrong on that. But it was interesting. If you look at the chest x-ray, you can actually see that the chest x-ray worsened throughout. There was the morning x-ray before, then the x-ray in the OR, and then one that afternoon and then one in the evening. You can just see his chest x-ray worsen throughout the day, which was pretty impressive.
What's the source of the hypertension? Why would he get hypertensive? Any idea? Okay. Weird physiology. Okay. Interesting. Okay. All right. Thank you to everybody.
Great work, all.
Thank you to MedStar for joining us this time. It was a blast to have you guys. So thank you, Dr. Sasser.
Thanks, Dr. Sasser.
Yeah, thank you for the invite, and we are looking forward to December.
Next quarter, correct? Is that the okay? We're looking forward to it.
Awesome. Thanks, guys.
Thank you all for having us.
Awesome work, everyone.